pelvis is a complicated structure composed of the two hip bones of the appendicular skeleton, as well as the sacrum and coccyx of the axial skeleton. A single hip bone can be called a pelvic bone, but also goes by the Latin name os cocci, and occasionally you may see the term innominate. That is from the Latin for no name or unnamed. Because the hip bone didn't look like anything in particular, they gave it no name, literally, though ironically it goes by several names. But you cannot call a single pelvic bone a pelvis. And while we've talked about some muscles of the pelvis and pelvic floor in prior lessons, we have yet to talk about the pelvis itself in any detail. Let's use a clinical scenario to set the stage for our study. One afternoon, a 68-year-old woman stepped out of her car and fell. She felt excruciating pain in her left hip and was unable to get up. The woman told paramedics that she didn't think she tripped over anything, the pavement wasn't wet or slippery, and she wasn't dizzy or disoriented. At the hospital, it became clear that she had broken her hip. So what exactly happened when she fell, and what specific bone did she break? First, we need to understand that each hip bone is composed of three major parts. The ilium is the more blade-like upright portion. The ischium is the more inferior and posterior region that we sit on, and the pubis is the more anterior region. During much of childhood, the ilium, ischium, and pubis are three separate bony elements that are united within the hip socket into a single functional element joined by cartilaginous growth margins. This complexity of each hip bone and its growth region allow the pelvis to grow in height, width, and depth during childhood. Once the cartilage areas ossify to bone, the adult ilium, ischium, and pubis are simply considered the three major regions of each hip bone. In the pelvis of both kids and adults, the two pubic bones are linked anteriorly by a cartilaginous joint known as the pubic symphysis. The pubic symphysis is an amphiarthrotic joint. A pad of fibrocartilage links the two pubic bones, allowing just a little bit of movement between them. In addition, the ilium of each hip bone is joined to the sacrum at a sacroiliac joint. The two sacroiliac joints are diarthrotic synovial joints in which a capsule contains a joint cavity lined with synovial membrane. The articular cartilage of these joints doesn't unite each ilium with the sacrum. Rather, a capsule of connective tissue surrounds and unites the adjacent bones, allowing greater freedom of movement in the sacroiliac joints than in the pubic symphysis, but still not nearly as much movement as many other synovial joints. On the ilium, there's a feature called the auricular surface. That's auricular, meaning ear-shaped from the Latin word for ear, not to be confused with articular, which means any joint surface. The auricular surface of the ilium is on the medial side of the posterior aspect of the bone. It forms a joint with the corresponding auricular surface of the sacrum. Together, these paired auricular surfaces form each sacroiliac joint, supported by anterior and posterior sacroiliac ligaments. These joints are how the two hip bones and the sacrum form the ring-like structure of the pelvis that protects and houses organs of the lower abdomen and the pelvis. But the auricular surface is just one of many landmarks on each hip bone. Let's start with some of the more obvious features. The socket of the ball and socket hip joint, in which the head of the femur sits, is known as the acetabulum. The acetabulum faces laterally, since we hang our limbs on the lateral aspect of both the pectoral and the pelvic girdles. And as we just learned, the acetabulum is also the site where the ilium, ischium, and pubis are united by cartilage in children. Superior to the acetabulum is the relatively flat area of the ilium, known as the iliac fossa. Its superior edge is known as the iliac crest, which terminates anteriorly in an anterior superior iliac spine, often abbreviated ASIS, and terminates posteriorly in a posterior superior iliac spine, often abbreviated as PSIS. We know by the rule of adjectives, if we have landmarks called superior, we'll have inferior counterparts. Just inferior to the ASIS is the anterior inferior iliac spine, abbreviated AIIS. And just inferior to the posterior superior iliac spine is a posterior inferior iliac spine, or PIIS. As in most other projections, these four prominences on the ilium serve as ligament or muscle attachment sites. Inferior to the ilium is the ischium. The bony prominences on which we sit are known as the ischial tuberosities. They're also the major origins for the hamstring muscles of the posterior thigh. As we learned in the previous lesson, the ischial tuberosities are often called the sit bones in yoga and other exercise classes. Because they're subject to pressures when sitting, the ischial tuberosities are also sites where those who are bedbound or use a wheelchair can develop decubitus ulcers, commonly known as bed sores, especially if their positions aren't periodically adjusted. The ischium has a pointed posterior projection known as the ischial spine. And above the ischial spine is a feature called the greater sciatic notch, and the lesser sciatic notch is below the ischial spine. A pair of ligaments, the sacrotuberous and sacrospinous ligaments, link the sacrum to the ischial tuberosity and the ischial spine, respectively. These ligaments turn the greater and lesser sciatic notches into the greater sciatic foramen and lesser sciatic foramen. These ligaments and the foramina they form are important to the integrity of the pelvis and relate the pelvis to the gluteal region and from there to the perineum. We'll talk more about these features later in this lesson. Extending anteriorly from the ischial tuberosity is the ramus of the ischium. We've used the term ramus before with relation to the nervous system, but ramus simply means branch. So the ischial ramus is a branch-like projection from the anterior surface of the ischial tuberosity, and it links with the inferior pubic ramus. Anterior to the acetabulum, the body of the pubic bone has both a superior pubic ramus and an inferior pubic ramus. Together, the superior pubic ramus, body of the pubic bone, inferior pubic ramus, and ramus of the ischium all help to surround and form the largest foramen in the body, the obturator foramen. Despite its large size in the skeleton, the obturator foramen is nearly completely covered by a membrane of connective tissue that is sandwiched by an obturator internus muscle on its deep side and obturator externus muscle on its superficial side. And this leaves only a small portion of this large foramen open for passage of the obturator nerve, artery, and vein. Now, some scholars think the large obturator foramen, also present in non-human mammals, may be similar to the holes in many dinosaur skulls, functioning to lighten the weight of such a large bone. The body of the pubic bone has a prominence known as the pubic tubercle, and that's often more pronounced in males. The pubic tubercle and anterior superior iliac spine are the attachments for the structure known as the inguinal ligament. I mentioned the inguinal ligament before when talking about the muscles of the abdominal wall. It's more or less like the rolled hem of the external oblique, internal oblique, and transversus abdominis muscles. Anatomically, the inguinal ligament is where the torso ends and the lower limb begins. As you may know, the pelvis is often the most obvious part of the skeleton in which male and female bony differences occur. This so-called sexual dimorphism is also seen in the body of the pubic bone itself. It's often more triangular in males and more squared in females. Related to this, females often have a more U-shaped subpubic region, an upside-down U, while males often have a more upside-down V-shaped subpubic angle. This difference is also because the female pelvis is wider from right to left, which relates both to the boxy pubic bone and wider subpubic angle. The male pelvis is typically taller, while the female pelvis is wider from side to side, with flared ilia. That's the plural of ilium. The female pelvis is also deeper from anterior to posterior, and as a result, has a larger greater sciatic notch, forming often nearly a 90-degree angle. Males typically have a much narrower greater sciatic notch, since their pelvis is usually more limited in both width and depth. Now, these differences come about during puberty when hormones influence bone development and muscle mass, among other body features. As a composite ring-shaped structure, the pelvis has a superior opening known as the pelvic inlet or pelvic brim, and a pelvic outlet inferiorly. When seen from above, the female often has a larger and roomier pelvic inlet, which helps facilitate childbirth. Males often have a narrower, more oval, and sometimes even heart-shaped pelvic inlet. Plus, the ischial spines and curved sacrum in males often encroach into the pelvis. Females typically have a flatter sacrum and ischial spines that don't jut into the pelvis, which could be problematic during childbirth. The pelvic outlet is also named relative to the direction of birth. It's outlined by the inferior aspect of the pubic symphysis, the inferior pubic rami, the ischial rami, the ischial tuberosities, both sacrotuberous ligaments, and posteriorly the sacrum and coccyx. Since I'm an anthropologist as well as an anatomist, I'll ask if you know why the human female pelvis is wider and roomier than that of the male. And I don't just mean why in females, but why in humans. As I like to say to my students, when your dog goes through puppy puberty or a cow matures during mooberty, does she get an hourglass figure? Nope. The reason that human females have more significant changes in the pelvis during puberty is because of the large size of the human fetal skull. Throughout human evolution, there's been a hand-in-hand, or should I say head-through pelvic inlet relationship between the increasing cranial capacity related to human intelligence over time and the size of the human female pelvis that must birth that giant noggin. The pelvis doesn't sit in us like a bowl. It's angled forward so that the anterior superior iliac spines and pubic symphysis are roughly in the same vertical plane. Also, if you've heard of the false pelvis and true pelvis, that distinction is between the area above the pelvic brim and below the pelvic brim. The true pelvis is the region below the pelvic brim in which pelvic organs are housed. By size, it's also called the lesser pelvis. The false or greater pelvis is the more open area above the pelvic brim, where our lower abdominal organs sit between the ilia. To better understand the hip joint and its ligaments, as well as the insertions of muscles that move the hip joint, we should also take a quick look at the proximal aspect of the femur. The femoral head is a rounded knob that faces medially and has a depression in its center called the fovea capitis, translated as the pit on the head. The femoral head constricts to a region called the neck of the femur. Laterally, there's a large bony prominence called the greater trochanter, and more distally, medially, and slightly more posteriorly is the lesser trochanter. Of all the bony prominences in the human skeleton, trochanters are only found on the femur. Anteriorly, running between the greater and lesser trochanter, there's an intertrochanteric line. Posteriorly, between the two trochanters, is more of a raised ridge called the intertrochanteric crest. Now let's focus more on the hip joint itself, which is different from the pubic symphysis and sacroiliac joints that help form the pelvis. The hip is a diarthrotic ball and socket joint between the acetabulum of the pelvic bone and the head of the femur. The rim of the acetabulum is not uniform throughout. At its anterior aspect, there's a deficiency known as the acetabular notch, but it's bridged by a connective tissue band known as the transverse acetabular ligament. The socket is also deepened by a rim of cartilage known as the acetabular labrum, and that it actually reaches around and clasps the head of the femur, unlike the glenoid labrum of the shoulder, which made the flat glenoid fossa broader but not deeper. The actual articular surface of the acetabulum is known as the lunate surface for its moon-like shape. It's covered with articular cartilage, as is the head of the femur. Unlike the shoulder, the hip has an intracapsular ligament, which means it's within the joint capsule itself, and it's known as the round ligament of the femur, or sometimes by the Latin name ligamentum teres femoris. It attaches the deep surface of the acetabulum to the fovea capitis on the head of the femur. The combination of this ligament within the capsule and the depth of the acetabulum, caused in part by the labrum, help make the hip quite stable. Remember, when compared to the shoulder, the hip has much less mobility, but has much greater stability. That's often a trade-off in some synovial joints. As a ball and socket joint, the hip is multi-axial, meaning it moves in X, Y, and Z axes of three-dimensional space. Anterior motion at the hip, like kicking a ball with a straightened knee, is flexion of the hip. Remember, forward is flexion at ball and socket joints. Returning the hip to standard anatomical position or moving the straight limb back, like winding up to kick, is called extension at the hip. What would we call lifting the lower limb out laterally, away from the midline? If you said abduction, that's correct. Pulling the thigh toward the midline is adduction. Turning the toes in with a straight lower limb is medial rotation at the hip, but pointing the foot out, directing the toes out away from the midline, is lateral rotation. And while in no way as great a range of motion as at the shoulder, swinging the lower limb in an arc is circumduction. Remember that the joint capsule is the sleeve of connective tissue that connects the bones in a diarthrotic joint, but not on their articular surfaces. In the hip joint, the capsule is composed of three ligaments that stabilize various aspects of the joint. And what's particularly helpful is that they're named for the three parts of the pelvic bone. There's an iliofemoral ligament, a pubofemoral ligament, and an ischiofemoral ligament. The iliofemoral ligament has the shape of an upside-down Y. It's anteriorly placed and passes from the anterior inferior iliac spine to the intratrochanteric line on the proximal anterior femur. The iliofemoral ligament is taut while standing and resists hyperextension to support our trunk without much additional muscle action at the hip. It's said to be the strongest ligament in the body. The pubofemoral ligament blends with the inferior aspect of the iliofemoral. It connects the pubic bone to the inferior aspect of the intratrochanteric line on the femur, and it limits excessive abduction and extension. The final ligament, the ischiofemoral, is part of the posterior aspect of the capsule. It spirals around from the ischium and attaches to the neck of the femur at its superior aspect. The ischiofemoral ligament also helps stabilize our standing position. In addition, all three of these ligaments, iliofemoral, pubofemoral, and ischiofemoral, help limit medial rotation of the hip, which would cause the femur to turn internally. Together, they make the hip joint extremely stable, not only when standing, but also during our bipedal locomotion. By the way, in case you're wondering how paleontologists know when upright walking began in our proto-human lineage, the depth of the acetabulum found in hominid fossils is a big clue. Now let's talk about some of the muscles that act on the hip, specifically the muscles of the gluteal region. There are not only 3 relatively large muscles with gluteal in their name, but also a series of 5 smaller muscles in the deep gluteal region. I suspect that gluteus maximus is among the first muscle names that most people typically learn, for whatever reason. Even kids seem to know the gluteus maximus is in the buttock, but likely they have no idea that there's a gluteus medius and gluteus minimus. Gluteus maximus has a broad origin along the outer ilium, the posterior aspect of the sacrum, the coccyx, and the sacrotuberous ligament, which remember connects the sacrum to the ischial tuberosity. The gluteus maximus inserts partly on the conveniently named gluteal tuberosity on the posterior femur, as well as on the iliotibial tract, often called the IT band, both of which we'll talk about more in the next lesson. But for now, remember that we wear the equivalent of a fascial stocking deep to the skin of the entire lower limb. The fascia lata is the region of this fascial stocking deep to the skin of the thigh, and not only does it help create the compartments of the thigh, but the fascia lata has a vertical thickening in its lateral aspect called the iliotibial tract, since it goes from the ilium to the tibia. Well, the lateral part of gluteus maximus inserts into that iliotibial tract thickening in addition to its insertion on the gluteal tuberosity of the femur. Due to its size, position, and fiber direction, the gluteus maximus has varied actions depending on what part of it is being used. As a whole, gluteus maximus is the major extensor of the thigh, as when kicking the thigh back. But it also extends the trunk, like when we're climbing stairs. That's why fitness stair machines, or simply taking the stairs at work or at home, strengthen the gluteus maximus. Extending the trunk is the action of gluteus maximus when we raise our torso after putting our foot up on the next step. That's also the same action that allows us to stand up from being seated on a chair, raising the trunk by extending both hip joints with our gluteus maximus muscles. Same with raising up during squat exercises. Because its fibers are directed laterally toward its insertion on the iliotibial tract and femur, gluteus maximus also helps laterally rotate the thigh at the hip joint, as when pointing your toes out away from the body. When used alone, the upper fibers can help other gluteal muscles abduct the thigh, while the lower fibers can help the muscles of the medial thigh to adduct the thigh. The inferior gluteal nerve off the sacral plexus supplies gluteus maximus, and that's its sole job. The inferior gluteal nerve exits the pelvis to reach the gluteus maximus by passing inferior to the piriformis muscle, thus its name. Piriformis is one of the deep gluteal muscles that we'll cover shortly, but remember, it's our landmark muscle for dividing up nerves of the sacral plexus. Deep to the lateral aspect of gluteus maximus are gluteus medius and minimus. Both of these are supplied by the superior gluteal nerve, which exits the pelvis above the piriformis muscle. Compared to gluteus maximus, the gluteus medius is also more superiorly placed, which is why it can be seen peeking out from superior to gluteus maximus. Gluteus medius is also the primary target for a clinician to give an intramuscular injection into the buttock. The needle should be placed in the superolateral quadrant of the gluteal region, which might hit the upper corner of gluteus maximus as well. In the previous lesson's clinical scenario, we learned what can happen when an injection is misplaced too inferomedially and hits the sciatic nerve. Both gluteus medius and gluteus minimus take origin on the outer surface of the ilium, from what are called its gluteal lines. and both insert on the greater trochanter of the femur, though gluteus medius's insertion is more laterally placed on the femur's greater trochanter, while gluteus minimus insertion is a bit more anterior on the greater trochanter. As a result of similarities in their origins and insertions, gluteus medius and minimus have identical actions. Both help stabilize the hip joint when we're standing, especially when we raise our opposite limb. Both also perform abduction of the femur at the hip joint, as well as aid in medial rotation of the lower limb at the hip. When seen in lab, gluteus medius and minimus appear almost like a single muscle with a neurovascular plane passing between them. The superior gluteal nerve artery and vein all dive between gluteus medius and gluteus minimus, serving gluteus medius from its deep side, but supplying gluteus minimus from its superficial side, which is rare in anatomy. After serving gluteus medius and minimus, the superior gluteal nerve continues laterally to meet a muscle we'll talk about in our next lesson, the tensor of the fascia lata. And those are the only three muscles served by the superior gluteal nerve. The 5 remaining muscles of the gluteal region are deep to the gluteus maximus. From superior to inferior, they are piriformis, superior gemellus, obturator internus, at least its tendon of insertion, then inferior gemellus, followed by quadratus femoris. Piriformis is a triangular-shaped muscle, with its base taking origin off the anterior sacrum and slightly on the sacrotuberous ligament. The apex of its triangular shape is its insertion on the greater trochanter of the femur, which it reaches by traveling out of the pelvis through the greater sciatic foramen, which, remember, is formed by the addition of the sacrotuberous and sacrospinous ligaments to the pelvis. Because piriformis attaches to the superior aspect of the greater trochanter, it can help abduct the thigh, especially when the hip is flexed. But it can also laterally rotate the hip. It's innervated by small segmental branches of the sacral plexus, which, remember, forms on the anterior surface of the sacrum from the braiding of the ventral rami of L4 to S4. Let's first cover the obturator internus muscle and then come back to the gemelli muscles. Obturator internus originates on the deep side of the rim of the pelvis's obturator foramen, as well as from the membrane that covers most of that foramen. The tendon of obturator internus leaves the pelvis through the lesser sciatic foramen that's formed by the crossing of the sacrotuberous and sacrospinous ligaments. The superior gemellus muscle flanks the superior edge of the tendon of obturator internus, and the inferior gemellus muscle flanks its inferior edge. Together, the 3 muscles insert into the medial aspect of the greater trochanter, near the intertrochanteric crest that runs posteriorly between the greater and lesser trochanters. Now, in the body, these 3 appear almost as one wide muscle with a single central tendon. In fact, early anatomists thought they were a single muscle. Then later, more detailed dissections and electromyographic studies confirmed that the 2 gemelli, plural of gemellus, which means little twin in Latin, were actually separate muscles from the obturator internus. The superior gemellus originates off the ischial spine, and the inferior gemellus originates off the superior edge of the ischial tuberosity. They don't pass through the lesser sciatic foramen, they originate on its lateral edge. Inferior to the inferior gemellus is the quadratus femoris muscle. It originates on the lateral edge of the ischial tuberosity and inserts on the intertrochanteric crest. Now, together, all of these muscles, piriformis, superior gemellus, obturator internus, inferior gemellus, and quadratus femoris, all laterally rotate the hip joint and help stabilize it. But there's a bit more to this historical story. The close proximity of the gemelli to the obturator internus and the mistaken relationships between them explains why early anatomists named their nerves as the nerve to obturator internus and the nerve to quadratus femoris. They only later found out that the innervation of obturator internus also supplied the superior gemellus, and the nerve to quadratus femoris also supplied inferior gemellus. Before leaving this topic, we need to go back to our clinical problem. Remember the lady who stepped out of her car and fell? That's the typical scenario in which someone says Mrs. So-and-so fell and broke her hip. Well, that's often not the sequence of events. It's actually the reverse. In many of these cases, the person breaks a hip, and that's what causes the fall. In this case, the woman's bones gradually became so weak that the very act of stepping out of the car that day was the straw that broke the camel's back, or in this case, broke the neck of the femur. It's not actually the pelvis or pelvic bone that broke. The weakened neck of the femur gave way when she put her weight on that left lower limb. When bone is demineralized by osteoporosis, a person's own body weight can be enough to cause a fracture. In this case, it's called a pathological fracture because the bone was already weakened by another condition, as opposed to a fracture caused by trauma. And the problem is, bone that weak will have difficulty healing, especially if the artery to the head of the femur is torn. It's a branch of the obturator artery that passes through the ligament of the head of the femur to enter the femoral head. If the ligament tears, truncating the artery, the head of the femur may develop avascular necrosis. Literally, the bone in that region will die from lack of blood supply. And so it won't heal, and a hip replacement will be needed. So let's move on to our next lesson and cover the other landmarks on the femur and the muscles of the thigh, since some of those also cross and act on the hip joint.